Okay, hello and welcome back everyone. The next part about autonomic nervous system will focus on the cholinergic antagonist pharmacology. I'm Dr. Hassan, professor of clinical pharmacology and drug therapy. We are going to speak about a lot of medication in this session today regarding to the cholinergic antagonist, but we need you to remember and focus on the main medication in this session. For example, we have atropine, atracurium, ipratropium, oxybutynin, and nicotine, and the last one, benzotropine. So we have a lot of medication, but we have key medication, keyword medication for us we need to remember. Let's get started. Okay, as you can see here in this slide, we have atropine, atracurium, nicotine, ipratropium, benzotropium, oxybutynin. Okay, you can see here list of medication for the clinical practice available belong to the cholinergic antagonist. So again, we need to remember our topic about cholinergic antagonist. Again, what is the meaning of antagonist? Antagonist mean any substance bind to the receptor and block the receptor. So we talk about cholinergic blockers. Atropine considered like muscarinic blocker. Atracurium considered like nicotinic blocker. Ipratropium considered like muscarinic blocker and so on. Less of medication. Okay, give me medication belong to the antimuscarinic agent. We have atropine, scopolamine, ipratropium. I will go with the highlight. Maybe we can use it as like highlight. Could be good highlight. So the most popular medication atropine. Then we have scopolamine. Then we have ipratropium, tiotropium, oxybutynin, toltridine, okay, glycopyrrolate, benzotropine. Okay, we have umeclidinium, aclidinium, dicyclomen. All these medication considered like one of the most important medication considered like anti-muscarinic agent. Moving to the neuromuscular blockers, we have succinylcholine. Okay, then we have atracurium and cis-atracurium. Then we have focoronium, recuronium, bancuronium, mivacorium, ribacorium. And if you see, we have suffix here with the ronium, rium. This is derived from curare. Moving to the last part, last group of medication belong to the cholinergic antagonist. We have ganglionic blockers. We have nicotine. We have hexamethonium, mecamylamine. We have trimethophan. We have bentolonium. So, but this one not popular in the practice. We don't use nicotine as treatment. We have it like to for patient who is willing to quit smoking. We can prescribe like a nicotine gum or nicotine patch. This is an important slide that explain what happened with when you prescribe atropine to your patients. You can see here when you prescribe atropine, atropine will when you prescribe atropine. Okay, when you prescribe atropine to your patient, atropine will bind to the muscarinic receptor, and atropine will prevent acetylcholine binding to the muscarinic receptor. So atropine block the muscarinic receptor and prevent acetylcholine from binding to this receptor. So what we have here, this slide, the important slide, show the atropine displace acetylcholine from the muscarinic receptor, occupy the receptor, block the receptor. So here we have blocking receptor. So acetylcholine block the receptor competitively. What happened here, if you like to overcome the action of atropine, so we try to increase level of acetylcholine by increasing concentration of acetylcholine. So therefore, acetylcholine will displace atropine, remove the atropine, and occupy the receptor. Again, we need to mention important things here. So what happened with the pen here, for example, When the atropine bind to the receptor, the result will be block the receptor. The result will be blocking the receptor. However, when the acetylcholine displaces atropine and binding to the receptor will be activated. Okay. Okay, anti-muscarinic agent inhibit muscarinic function by blocking the muscarinic receptor. Atropine competitively bind to the receptor, prevent acetylcholine from binding. So what we have here, we try to understand what is the effects of acetylcholine on the heart. So here we focus on what is or are the effects of acetylcholine on the heart. So we're looking on the heart, what happened there. So this is a normal situation here before prescribing atropine. The acetylcholine released, and this is a normal life. When the acetylcholine arrives to the heart, we have M2 receptor, muscarinic receptor in the heart. We know that from pharmacodynamic and previous slide, M2 receptor activate GI protein. You see it here, GI protein, and this will inhibit adenylate cyclase, decrease cyclic AMP. This will lead to the bradycardia, decrease heart rate, decrease contractility. So this explains why acetylcholine causes bradycardia through the M2 receptor GI protein and decrease cyclic AMP. So three steps. Number one, binding to the M2 receptor, activate GI protein, decrease cyclic AMP. What happened when you prescribe atropine to the patient? So if you look on this is number one here. This is number one. So what happened when you prescribe atropine to your patient? This is the atropine. You can see the atropine here. So when you prescribe atropine to your patient, the atropine block the M2 receptor. The atropine block the M2 receptor, and we know that M2 receptor cause inhibitory effect. What happened there? The atropine inhibit the inhibitory effect. You see the minus here, and we see the minus here. So we have two minus. So we have atropine block the inhibitory effect of M2 receptor, block the GI receptor. So the situation here, when you block the muscarinic receptor, I need to maybe explain something here. I hope the pen working now. No, the pen stopped working. I don't know what happened. So what happened in the heart? In the heart, we have two main system. We have sympathetic system, then we have parasympathetic system in the heart. So two system control the heart. So we have sympathetic and parasympathetic. So the heart under control of sympathetic and parasympathetic. So what happened here when you prescribe atropine to the patient? When you prescribe atropine to the patient, the result will be inhibit parasympathetic system. So when you inhibit parasympathetic system, this will activate like compensatory mechanism. This will activate sympathetic system. Okay, so activation of sympathetic system, this will lead to the increased heart rate and increased conductancy. Okay, this will explain what happened there. So if you go back to the slide again, what happened, you can see here when you have this issue here, atropine block muscarinic receptor, block acetylcholine, the result will be increased compensatory activation of sympathetic system. This will lead to the increased chronotropy and the dromotropy. That mean talk about the increased heart rate and increased conductancy. Okay, this is the first explanation for the atropine on the heart. Very important effect we need to remember and address. Moving to the next slide. Okay, so the next slide explain the action and uses. As you can see here, effect on the heart, atropine cause the tachycardia, increase heart rate. Okay, respiratory system, atropine cause bronchodilation and decrease secretion. Gastrointestinal system, decrease motility, increase secretion. Decrease mortality and decrease secretion. And the eye, mydriasis, cycloplasia, but unable to accommodate, loss of accommodation. So two main effects on the eye, mydriasis and cycloplasia. Okay, in the nervous system, atropine causes stimulation of nervous system. Clinical use of atropine, we use it for the patients suffer from bradycardia. We use atropine for patients suffer from bradycardia. We use atropine in preparing patient for general anesthesia and surgery. We use atropine for patient as antidote for organophosphate poisoning. We use atropine for eye examination to induce mydriasis. We use atropine for the patients from spasm, gastrointestinal spasm. We use atropine for patients from overactive bladder. We use atropine for patients from atrial ventricular block. So all these maybe less the action of atropine. So number one, treatment of bradycardia, prepare patient for general anesthesia, antidote for organophosphate, eye examination to induce by inducing mydriasis, antispasmodic. We use it for treatment of gastrointestinal spasm, reduce hypermotility of the urinary bladder. If someone suffers from overactive bladder, we use atropine. If the patient suffers from AV plaque, atrial ventricular plaque, we can use atropine. If you need more detailed information, this slide here provides in-depth detail about the actions and clinical use of atropine for bradycardia, anesthesia, antidote, ophthalmic use, GI spasm, and so on. Okay, the antimuscarinic adverse effect. Regarding adverse effect of antimuscarinic agent, as you can see here, with depends on the dose. When you have low dose, the patient may suffer from a dry mouth, blurred vision, tachycardia, constipation. Speaking about the high dose, here the situation will be affect the brain. The patient suffer from restlessness, confusion, hallucination, delirium. Okay, moving to the adverse effect, we have a less of medication, long list of medication regarding the atropine. As you can see here, atropine adverse effect, we have cardiovascular, atropine cause tachycardia, palpitation, arrhythmias, atropine cause confusion, restlessness, hallucination, delirium, dry mouth, constipation, reduced motility, atropine cause the blurred vision, photophobia, increased intraocular pressure, respiratory. So this is important concept here. That means it's not as considered like contraindication. So because this medication is considered like contraindication in patients who suffer from glaucoma. So atropine, because atropine increase intraocular pressure, therefore it's considered like contraindication in patient. Contraindication in patient with maybe suffer from glaucoma. The dry respiratory, decreased respiratory secretion and decreased clearance of secretion. Urinary retention, atropine cause urinary retention. We need to remember that. Then we have difficult urination. In this case, we need to remember this medication is not allowed to use in the patient suffer from prostatic uh, benign prostatic hyperplasia. It's not allowed to use it. Now we have two cases: glaucoma, not allowed to use atropine. Benign prostatic hypertrophy is considered like contraindicated. Okay, speaking about other anti-muscarinic agent, we have list of medication belong to the muscarinic agent. We have scopolamine. Scopolamine, this medication used to prevent motion sickness, available like transdermal. Then we have ipratropium. Ipratropium is available inhaler, Atrovent, used for patients suffer from COPD and asthma. Oxybutynin, Detropan, used for overactive bladder and urinary incontinence. Toltrodine belong to the same group, toltrodine and oxybutynin. Darphenocin, solifenacin, the same. Benztropine, cognitin, used for patients from Parkinson disease. Trihexyphenidyl, the same for Parkinson disease. Glycopyrrolate, used for patients from increased secretion. So glycopyrrolate dry the mouth, decrease secretion. Dicyclomine, bentyl dicyclomine, used for patients from irritable bowel syndrome. Tropicamide, midrayacil, used for patients used to induce mydriasis and cycloplasia. So here we have list of medication. Here you have the clinical use. So I will repeat what we have for other antimuscarinics: scopolamine, ipratropium, tiotropium, oxybutynin, darphenocin, solifenacin, benzotropin, trihexyphenidyl, glycopyrrolate, dicyclomine, tropicamide. Okay, the question now: which of these medication used for prevention motion sickness? So I will go the highlight now. Okay, which of these medication used for prevent motion sickness? Scopolamine. Which of these medication used in patient with asthma and COPD? Ipratropium and tiotropium. Which of these medication used for overactive bladder and urinary incontinence? We have oxybutynin, toltrodine, darphenocin, solfenacin. Which of these medication used for Parkinson disease and drug-induced extrapyramidal symptoms? We have benztropine, trihexyphenidyl. Two medication for Parkinson disease. Which of this medication used for chronic drooling, increased excessive salivation or saliva? So we have glycopyrrolate. Which of this medication used for irritable bowel syndrome? We have the dicyclomine, bentyl. Which of this medication causes mydriasis and cycloplasia? Tropicamide, midrayacil. Okay, this text slide present information for every medication we use it. We have scopolamine. We have the scopolamine here for motion prevention of motion sickness, for example. Ipratropium, tiotropium for COPD and asthma, as you can see here. Then we have oxybutynin, toltrodine, darphenocin, overactive bladder and urinary incontinence. Benztropine for Parkinson disease. Glycopyrrolate for reducing secretion, glycopyrrolate. The cyclomine for IBS, irritable bowel syndrome. Okay, in this Google Images, I share with you some picture for our medication. We have scopolamine as a skin patch for motion sickness, for example. Then we have ipratropium, and you can see the ipratropium as inhaler used for asthma. Then we move to the oxybutynin, and you can see the image here, oxybutynin for overactive bladder, and especially in women. So we finished the discussion of cholinergic antagonist by focusing on the antimuscarinic agents such as atropine, ipratropium, oxybutynin, and different agent belong to the anti-muscarinic agent. The next stage or next step will be talking about the neuromuscular blocking drugs. Here we are speaking about the nicotinic receptor, the medication block the nicotinic receptor or stimulate the nicotinic receptor. What happened and what medication we use, what is the clinical use, is there any side effect or contraindication? Okay, let's get started with the next part of cholinergic antagonist on the level of nicotinic effect. Okay, speaking about the neuromuscular blocking drugs, NMBAs, neuromuscular blockers or neuromuscular blocking agents. Here we are talking about a group of medication, a class of medication that cause temporary paralysis by blocking cholinergic transmission between the motor nerves ending and the nicotinic receptor on the motor end plate of the skeletal muscle. So the situation here, this group of medication block nicotinic receptor on the level of skeletal muscle. We have two main medication. Number one, we have depolarizing medication. Then we have non-depolarizing medication. So the two group of medication belong to the neuromuscular junction blockers. We have depolarizing agent and non-depolarizing agent. Normally, this medication used for general for general anesthesia to facilitate general anesthesia. This medication used for endotracheal intubation. This medication could be used to provide skeletal muscle relaxation during surgery. Okay, so you can see here from the slide what we have. Let me go to the pointer here. I prefer the laser more than pointer. Well, you can see the neuron here. You can see the neurons, and the neuron release the acetylcholine. When acetylcholine connected with the skeletal muscle, so attach the neurons with the skeletal muscle. We call this one neuromuscular junction. Now, when the acetylcholine release activate the nicotinic receptor here and cause a action potential. So I will go to the slide here on the other hand. So the acetylcholine release in the synaptic, then acetylcholine, you can see here the green ball, the acetylcholine binds to the nicotinic receptor, okay, and the acetylcholine bind to the nicotinic receptor. When acetylcholine bind to the nicotinic receptor, okay, acetylcholine bind to the nicotinic receptor. This will open sodium channel, allow sodium to enter the cell. When the sodium enters the cell, cause action potential, depolarization. This will lead to the skeletal muscle contraction. Now we understand what happened with the effect of releasing of acetylcholine. Acetylcholine affect the nicotinic receptor and causing skeletal muscle contraction. Okay, list of medication belong to the neuromuscular blocking agent, blocking drugs, non-depolarizing agent. We have non-depolarizing agent. We have the non-depolarizing agent, and then we have depolarizing agent. Regarding non-depolarizing agent, we have list of medication. We have rocuronium, fucuronium, Atracurium. Then we have Atracurium, bancuronium, mifacorium. For depolarizing agent, we have one medication and this group only, Succinylcholine. Okay, what happened here? What is the description for this group of medication? These drugs, neuromuscular blocking agent, are critical in modern anesthesia and the critical care setting. We use it for general anesthesia. So it's very important to address this group of medication, neuromuscular blocking agents. How this medication work? This medication bind to the nicotinic receptor. Okay, blocking the receptor, bind and block the receptor, prevent depolarization. This will lead to the inhibit muscle contraction. This will lead to the skeletal muscle relaxation. So this medication, group of medication, considered like non-depolarizing blocker, less of medication, tobocorarine, bancuronium, mifacorium, atracurium, atracurium, fucuronium, ricuronium. This medication bind to the nicotinic receptor, Okay, this medication prevent depolarization and cause skeletal muscle contraction. So now the question, which of the following drugs is used in general anesthesia to induce skeletal muscle relaxation? So we have list of medication, atracurium, cis-atracurium. How this medication work? Bind to the nicotinic receptor and cause relaxation. Okay, so here what we have, when the patient going to the general anesthesia and the surgery, we prescribe atracurium. You can see the atracurium here as particles or as drugs. Atracurium bind to the nicotinic receptors. So before we go there, this is the first one here, the normal, healthy, normal subject. We have acetylcholine binding to the nicotinic receptor, opening sodium channels, lead to the action potential, skeletal muscle contraction. This is a healthy subject before anesthesia or general anesthesia. The patient prepare for general anesthesia. We prescribe atracurium to induce skeletal muscle relaxation. What happened? We inject atracurium IV. Atracurium will go to the nicotinic receptor. Atracurium, you can see it here, binding to the atracurium binds to the nicotinic receptor, black nicotinic receptor, displace acetylcholine, prevent acetylcholine from binding to the nicotinic receptor. There is no action potential here. The muscle will suffer from skeletal muscle relaxation. So we prepare the patient for surgery by induced skeletal muscle relaxation. That will be happened by giving an atracurium, that black nicotinic receptor. So blocking nicotinic receptor will lead to the skeletal muscle relaxation. Okay, now we have skeletal muscle relaxation and we finish with the surgery. We need the patient to recover from the skeletal muscle relaxation. We don't need skeletal muscle relaxation and paralysis to remain forever. We need the patient to recover and go back home walking. Okay, so what we have here, you can see we don't prescribe acetylcholine in the clinical practice. We don't have acetylcholine treatment because acetylcholine considered like very short half-life, number one. Okay, as we discussed, we don't use acetylcholine in the practice for two main reasons. Number one, acetylcholine has multiplicity of action, number one. Number two, acetylcholine has very short duration of action, millisecond. So the acetylcholine will be vanished from the blood, from the plasma, from the neurons due to the enzyme available there. So what we can do to increase level of acetylcholine and what we can do to increase level of acetylcholine on the side on the neurons, the best way to prescribe something called acetylcholinesterase inhibitor, ACHEIs. If we prescribe neostigmine, visostigmine, pyridostigmine, this will inhibit the enzyme responsible for metabolism of acetylcholine, and the acetylcholine concentration will be increased, and this will follow the low mass of action. Acetylcholine, we have more particles now. Acetylcholine will displace the atracurium from the receptor and occupy the receptor. It stimulates the receptor, cause action potential and skeletal muscle contraction. This is the recovery. So this is the best way to help and assist in the recovery of patient after surgery by prescribing acetylcholinesterase inhibitor. Okay, regarding this, number one, regarding the succinylcholine, and someone may ask what is succinylcholine. If you go back a little bit, few slides to show you what is succinylcholine here. So you can see the succinylcholine here in this slide. The succinylcholine considered like depolarizing agent. How this medication work? So we explained already how this group of medication works, such as atracurium, and a less of medication work on the similar mechanism. However, succinylcholine work on different mechanism. Okay, this is the succinylcholine working here. When you prescribe succinylcholine to your patient IV, the succinylcholine will displace the acetylcholine, occupy the receptor. What happened here? Succinylcholine bind to the receptor, occupy the receptor, stimulate the receptor, depolarization. So this will cause stimulate action potential skeletal muscle, and the patient may suffer from twitches muscle and fasciculation, skeletal muscle contraction. This is phase one. So when succinylcholine administered, succinylcholine bind to the nicotinic receptor. You can see the plus here. Succinylcholine will activate the receptor, cause action potential, short duration of action. Okay, phase two, what happened here? The receptor will becomes desensitized. The receptor become desensitized, unresponse to anything. Succinylcholine will be metabolized in the plasma. When the acetylcholine come and try to bind, the acetylcholine cannot bind to the receptor because we have conformational change. We have changes in the receptor shape. So we call this one phase two, desensitize. So acetylcholine come and to bind to the receptor, but cannot bind due to the desensitization of the receptor, and this to lead to the skeletal muscle relaxation or muscle paralysis. So now we understand the situation for succinylcholine. Phase one will be depolarizing, activate. Phase one, depolarizing, activate by binding to the receptor. Phase two, desensitize, unable make a like conformational change in the receptor. The acetylcholine unable to bind to the receptor. This will lead to the prevent further action potential, skeletal muscle relaxation, and muscle paralysis. Again, the slide here give a more detailed description about succinylcholine. Succinylcholine, like consider like a neuromuscular depolarizing agent, neuromuscular depolarizing agent used in general anesthesia. Succinylcholine present two phases: phase one, depolarizing agent; phase two, desensitizing agent. And the phase one may cause muscle contraction, muscle fasciculation, and phase two associated with the inhibition of the neurotransmitter. Okay, this is an important slide, important table to discuss and remember. Okay, important table. The first one here, we need to remember which one is like duration of action, elimination, and properties of the medication. I will start with the first one, succinylcholine, nicotine, succinylcholine, ultra short duration of action. It's between the duration of action between 5 to 11 minutes. Elimination, we have enzyme in the plasma called plasma cholinesterase. So the plasma cholinesterase, we have plasma cholinesterase responsible for metabolism of succinylcholine. Succinylcholine considered like ultra short duration of action. Okay, 5 to 11 minutes. Ditobocurarine, long duration of action. Competitive, 80 minutes. We don't have it in the practice. Atracurium, intermediate duration of action, and will be metabolized spontaneously. Duration of action 45 minutes. Atracurium, NMBAs, intermediate duration of action, competitive. Okay, spontaneous metabolism 45 to 90 minutes. Mivacorium, short duration of action, plasma cholinesterase metabolism 15-20 minutes. Bancaronium, long duration of action, competitive. You can see here bancaronium mainly metabolized in the liver, 80% in the liver, bancaronium. And duration of action for bancaronium, 85 to 100 minutes. So I will say here in this slide, bancaronium considered the longest neuromuscular blocker, 100 minutes. Okay, give me medication considered like ultra short duration of action, succinylcholine. Okay, moving to the recoronium intermediate action, focuronium intermediate action. What happened with the metabolism? Okay, you can see here focuronium, recoronium mainly metabolized in the liver. Okay, about 75 to 90% mainly metabolized in the liver. And consider intermediate, recoronium, focuronium, between 40 to 70 for both. 40-70 minutes for recoronium, focuronium. So recoronium, focuronium mainly metabolized in the liver. Intermediate duration of action. competitive binding to the receptor, competitively binding to the receptor, and short duration of action between 40 to 70 minutes. Again, from this table here, we need to remember the medication name and how this medication work. For example, succinylcholine considered like depolarizing agent, Atracurium considered like non-depolarizing agent. Which one considered like long duration of action? We have bancaronium. Which medication metabolized mainly in the liver? Bancaronium. Which medication has long duration of action? Bancaronium. Which medication considered like ultra short duration of action? Succinylcholine. Which medication mainly metabolized in the plasma? We have succinylcholine and mifacorium, and so on. Okay, this slide here, this slide demonstrates the clinical use of neuromuscular blocking drugs. We use it to induce skeletal muscle relaxation before surgery to prepare patient for surgery, number one. Number two, we use it for the facilitate endotracheal intubation. Number three, to control ventilation. Sometimes we use it for some case or to treatment of convulsions. Not like ideal treatment, but could be option on the table to treat convulsions. And the right side here, they present and remind us with the list of medication belong to the neuromuscular blocking agent. We have non-depolarizing agents. We start with the atracurium, cisatracurium, recuronium, fucuronium, bancaronium. We have depolarizing agent, one medication, succinylcholine. This slide here addresses some adverse effect of these neuromuscular blocking agent, atracurium and tobacurarine. They found these two medication may be associated with hypotension, bronchoconstriction due to the histamine release. So this number one. They found bancaronium may cause increased heart rate due to the vagolytic effect. When you talk about vagolytic effect, here we talk about the atropine effect. Succinylcholine may lead to the opening potassium channels, and this may lead to the cardiac arrest. So you can see here we have some significant side effect associated with each medication: atracurium, cisatracurium, hypotension, bronchoconstriction due to the histamine release. Bancaronium, vagolytic effect such as atropine, increased heart rate. Succinylcholine opening so the potassium channel may cause cardiac arrest. Okay, regarding adverse drug reaction, we have a case called malignant hyperthermia. This is anesthesia-related complications, especially with the succinylcholine, especially with inhalation agent used for general anesthesia. So as you can see here, malignant hyperthermia considered like a rare life-threatening reaction, associated by certain anesthetic drugs in genetically susceptible individuals. That means this malignant hyperthermia does not occur in all patients, and the patient who has suffered from genetic susceptibility may suffer from malignant hyperthermia. Medication may cause malignant hyperthermia, succinylcholine, and volatile anesthesia such as halothane and sevoflurane. So two group of medication may cause malignant hyperthermia: succinylcholine and volatile anesthetics such as halothane and sevoflurane. Okay, what happened here? So how we can explain malignant hyperthermia? So when you prescribe this medication to the patient, the consequences will be increased release of increased amount of calcium release from the sarcoplasmic reticulum through the channels called ryanodine receptor channels. So when you prescribe succinylcholine or halothane to the patient, the sarcoplasmic reticulum through the ryanodine receptor will release a large amount of calcium, and this will lead to the muscular rigidity and hyperpyrexia. What that mean with hyperpyrexia? That mean fever or high fever, and muscle rigidity, severe muscle contraction. So with the malignant hyperthermia, we have two main issues. Number one, muscle rigidity. Number two, high fever or hyperpyrexia. The etiology, increased release of calcium from sarcoplasmic reticulum from the ryanodine receptor channel. If the situation complicated, the patient may suffer from kidney failure, abnormal heart rhythm, life-threatening metabolic imbalance. How to treat the patient here? Malignant hyperthermia management include prescribe dantrolene IV for the emergency, cooling the patient. We go with some supportive measures here. Okay, how the dantrolene work? When you prescribe dantrolene to your patient, dantrolene bind to the ryanodine receptor RYR1, a block opening the sodium, the ryanodine receptor, a block release of the calcium. Okay, this image here explain what happened when you prescribe succinylcholine to your patient or volatile anesthetics such as halothane. And you can see here the succinylcholine activate and then block the nicotinic receptor, may cause malignant hyperthermia, allow calcium to enter the cell. What else? Also, the sarcoplasmic reticulum start releasing calcium through the ryanodine receptor to the cell. This will lead to a large amount of calcium in the skeletal muscle. This will cause muscle rigidity and hyperpyrexia. Okay, this will conclude our lecture for today regarding the cholinergic antagonist. We discussed the antimuscarinic medication. We discussed the neuromuscular blocking agents such as depolarizing and non-depolarizing agents. In this case, we almost cover the principal introduction to autonomic nervous system. We cover the cholinergic agonist. The third part will already covered with the cholinergic antagonist. So next session will be focusing on the adrenergic agonist and adrenergic antagonist. Stay tuned and see you soon. Have a great day, everyone.